Hello and good day, everyone. Welcome to today's webinar on innovative strategies for sustainable health financing, where hopefully in the next 80 minutes or thereabouts, we'll be delving into how to navigate budget constraints in the changing global landscape. My name is Abu Talib Abdul Salam, and it's my honor to facilitate this session. I work at ACE Group, which is an organization committed to building innovative and sustaining solutions to development problems. And this webinar is the first of our webinar series designed in part to drive meaningful dialogue, but also to share knowledge and promote best practices in healthcare financing in Nigeria. To provide a bit of context, right? Health finance is a critical pillar for universal health coverage and sustainable health systems. And in Nigeria and even the African subcontinent, it's been quite challenging. Historically, official development assistance has contributed significantly to how we are able to fund healthcare initiatives across HIV and AIDS, tuberculosis, malaria, maternal and child health programs. But more recently, in recent years, we've had donor fatigue, issues around shifting global priorities, stuff around political ideology changing, and also global economic downturn, really, which has meant that international aid has dwindled a bit. The most dramatic of which has been suspension of financial contributions to WHO and the freeze of USAID funding by the United States government. While we acknowledge this challenge, we also view this as an opportunity to scale up local solutions through innovation and rigorous implementation. And this discussion promises to highlight these opportunities. We are thrilled to have you join us for this discussion. It's going to be insightful and engaging. Whether you are tuning in from within our region or from across the globe, good day once again. And we appreciate your time and commitment to being part of this conversation. We have a fantastic lineup of speakers, right? To borrow from Hollywood speak, I'll say a star-studded lineup who will be sharing their expertise and insights on this topic. Dr. Gafar Alawode, who is the CEO of DJI Consult, is our keynote speaker. Our panelists are Dr. Muntaqa Umar Sadiq, who is being represented by Alajire Gafar. Apologies if I didn't pronounce it as appropriate. I also have Dr. Raihanah Ibrahim, who is the principal and director at Solina Center for International Development and Research, and Dr. Yakubu Agada, who is the director of Standards and Quality Assurance at the MHIA. The panelists and the keynote speaker have actually been carefully curated for this audience based on the stellar work that they've done over the course of their careers across resource mobilization, pooling, and also purchasing. So there will be an opportunity for audience engagement. So we encourage you to use the chat section. Also endeavor to mute your mics when you're not speaking. To just go over the house rules quickly before we dive deep into the conversation. I want to announce that the meeting is being recorded, but it's really for record keeping and promotional purposes. Also, we are not mandating for participants to turn on their videos. And as I've said previously, use your Q&A icons to ask questions. And during the Q&A sessions, if you need to ask a question and you need to unmute your mic, indicate by a raise of hands. Once again, thank you for being here. And without further waste of time, I would like us to dive right in. And to set the stage for today's discussion, it's my pleasure to introduce Dr. Gafar Alawode. He is a health system expert with extensive experience managing donor-funded health system strengthening projects in Nigeria, Liberia, and Uganda. He has held senior roles, including being the country manager for Liverpool Association of Tropical Health, chief of party for USAID-funded health finance and governance projects, and being the country director for Health Policy Plus. He's played key roles in advancing universal health coverage in Nigeria and designing initiatives such as Legislative Network for UHC and the Nigeria UHC Forum. He was appointed to the World Bank Health Financing Resilience Committee of Practice, and he has led teams of experts who prepare policy position papers that advises the 54 Commonwealth Ministers of Health on effective aid utilization and domestic resource mobilization. His research interest includes policy analysis on health taxes and local government autonomy in relation to primary healthcare and most of his research is funded by USAID and AHPSR. He's currently the CEO of Development Governance International Consult. He holds a medical degree from the University of Illinois and a master's degree in tropical medicine from the Liverpool School of Tropical Medicine. He also has a wide range of executive trainings, health system management, and is a member of the UK Faculty of Public Health and is a fellow, also a fellow of the Academy of Public Health. We are honored to have him present our keynote speech. Ladies and gentlemen, Dr. Alawode. Over to you, Dr. Alawode. All right, it seems that we have a bit of a challenge with
So
uh
I'm here. I'm here
all
with
right.
you.
Yes. Over to you, Dr. Gafar.
Okay, thank you very much, and good afternoon, good morning, good evening, everyone, depending of where you are joining from. The pleasure is mine to join this webinar and share my thoughts on impact of foreign aid reduction in Nigeria's health system and to kickstart conversation on sustainable financing for health. Next slide, please. So I'll be going through this outline where we'll be looking at financing situation in Nigeria and service coverage, landscape and implication for financing Nigeria, the importance of transitioning to sustainable financing. What are those innovative financing options, lessons learned, and key recommendations? Next slide, please. So as a background, it is very, very important to actually situate where are we in terms of health financing in Nigeria against established benchmark. At the same time, to look at where are we in terms of service coverage. As most of us have already known, health financing in Nigeria is, especially public financing for health, is suboptimal against every parameter in terms of per capita spending on health in terms of proportion of health government's budget that is spent on health and as a proportion of GDP. Uh, no, previous slide, please. Yes, proportion of GDP, we are not there in terms of health financing landscape. But what is important is that this is actually translating to suboptimal coverage of services using looking at universal coverage service coverage index, which measure the coverage of key services of health. This is one of the most important parameter to measure health system performance. So if you look at it since the beginning of the millennium, of course, we have only moved from 20 to around 38 on a scale of 0 to 100, where we have persistently below the performance of average performance of sub-Saharan Africa. Next slide. So let's now look at what is the global landscape for development assistance for health before we now bring it down to Nigeria. So if you look at since the beginning of the sustainable development at the end of the Millennium Development Goal, the external financing for health has actually plateaued. It rises very drastically at the beginning of the Millennium Development Goal year 2000 until around 2015, where it had actually stopped growing until recently during COVID when it spiked again. And then out of this spending, United States government spending is very a huge proportion of the total spending. But what this one is telling you now, even before the United States government decided to pause aid, it is well established that it is not actually reliable in terms of going forward. How do we finance health effectively? So next slide. So in terms of let's now focus more on the U.S. government contribution to global health funding. So you will see that in terms of the global health funding, spending of United States is actually bigger than the next 10 countries combined. What does that tell us? That United States government plays a huge role in terms of spending for health globally. And they do this through several channels. The other is through several channels, through the money they are spending, through their government agency, like you said, SCDC, and through other channels like WHO, Global Fund, Gavi, and others. So this is just to set the stage that if the United States decide to pause funding on health, it's going to have huge implication because they are the giants when it comes to this. So next slide is telling us in the situation of Nigeria, the money that we spend on health, where does the money come from? So this chart is looking at uh, current expenditure, with the total health expenditure that we are spending. And the yellow part of the bar chart is telling us that the bulk of the money that we spend on health in Nigeria comes from out of pocket, which most of us are actually familiar with. The next is the government spending, and the next is the donor spending. So if you can see from that chart, though on average, donor funding or external financing constitutes around 10% of the total health spending. This become more significant. Next slide. This become more significant when we look at spending on program areas. And let me start with uh, funding or spending on HIV/AIDS, specifically spending on HIV/AIDS treatment. 94% of the money that we use in Nigeria to fund HIV/AIDS treatment is come from external financing, because Nigeria is one of the 10 countries, 20 countries that depend most of external financing on HIV/AIDS treatment. Half of the money is from United States government. The same thing applies to financing the TB that you can see. Financing from TB is substantially from external financing. And why the external financing has been on the rise, the domestic financing is actually not increasing to that level. The same thing applies to family planning. As we can see, funding for family planning uh, is largely from outside. And the same thing applies to other program area, immunization, malaria, and others. So next slide. So I think this has set the stage for us to look at how do we ensure improve domestic financing for health, because we have already established that the amount of money that we are spending is suboptimal, and the service coverage is suboptimal despite the external financing that we are receiving. And now the biggest spender is telling us they are not going to spend more. So that is why we have to look inward. Why it is important to look inward again? One, all the countries that have made progress in terms of universal health coverage, they did so by spending a large proportion of their money on health. That is number one. Number two is only domestic financing that can guarantee sustainability. All of us can see do not come, do not go, and as much as possible. But it's the donor domestic money that can guarantee sustainability. Another aspect is equity. So take for instance, Nigerian government is spending money on basic care provision fund. Basic care provision fund is everywhere in Nigeria. There is no other sources of external financing that actually go that far in terms of equity covering every nook and cranny. Then the last aspect why it is very, very important to look at domestic financing is that social protection, especially social protection in health, is an important element of the social contract between the government and the government. So for this very, very important reason, it's extremely important to look at domestic financing. But the question is the question of how, which we are going to be answering next. So in terms of our next slide, in terms of what is the strategy based on evidence, based on practice, based on what has worked. So based on what has worked, two things are very, very important. One, we have to identify what is the opportunity for us to spend more and spend well. That is one. Then the other thing is how do we convert those opportunities to the reality of improved sustainable financing. So answering the first question, and what is the opportunity for spending more and spending better or on health. So first and foremost, the starting point in the journey of sustainable financing is to first of all have a very good picture of the public expenditure on health to start with. How much are we spending Where are we putting this money? What is the opportunity to spend it better? What is the proportion of what is allocated that is being released? Where are we spending the money on? Are we spending on the right priority? Another aspect is to look at what is the need in terms of our major need in the health sector that will help us to achieve our objective in terms of our need around human resource, drug infrastructure, and others, so that to ensure that our financing aligns with this. And then we need to look for where would the additional money come from in terms of fiscal space analysis, looking at established framework, looking at macro fiscal environment. Is it possible to reprioritize? Can we here mark money like basic care provision fund? How do we achieve efficiency gain? So all these will help us to identify what is the opportunity to spend more and spend well. But you agree with me that it is not enough just to find out what are the opportunities. How do we convert opportunity to reality? So two things we have to do. We have to look at what is the governance environment for health financing. Do we have a dedicated unit in the Ministry of Health that is looking at health financing? Do we have a multi-sectorial structure that bring people together to see, because health financing is beyond Ministry of Health. Ministry of Finance, Economic Planning, and as National Assembly, State Assembly, they have the role to play. How do we ensure that the political economy, there is right political appetite for improved spending? Then again, another thing we need to look at is to address the public financial management challenges, to understand the language of people in the Ministry of Finance. What are the bottlenecks to allocation? What are the bottlenecks to releases? And how do we remove these bottlenecks? So next slide, then we'll be looking at successful resource mobilization for health in Nigeria. The good news is that it is actually possible. There are a lot of great examples where people have invested in domestic resource mobilization and they have gotten results. We have seen more than 500% increment in HIV expenditure in Lagos State. We have seen the federal government spending on some program areas which they were not spending before, like of family planning, immunization, cancer, health security, basic care provision fund. We have seen creation of budget lines in some states like Kano and other on health security, and we have seen successful integration of TB and family planning into a health insurance scheme in Lagos and elsewhere. But looking at this, next slide, looking at all these, I think it is still very, very important to look at what are the innovative financing options, because within the existing traditional options that we have, you will discover that there is a huge competition. That is why the allocation to health at the federal level has not gone beyond 5-6%. All this why? Because the government will give you reason why, because they have to spend on security, spend on everything. So we have to look at innovative financing option. And I'll be using an example of a fiscal space analysis on around innovative financing that was done by USAID LHSS with the support of DJI Consult. So the slide we are looking at is showing like business as usual in terms of what is operational now, what is available now. If you look at financing for vulnerable group fund, for example, so the only available pool of fund at the resource at this moment is basic care provision fund. And as a result of that, more than 90% of the vulnerable population, vulnerable defined in terms of poverty, because multidimensional poverty says that more than 40% of Nigerians are multidimensionally poor. So if you look at that pool of people and available resources, is only more than 90% of them would not be covered. So that actually led to fiscal space analysis where we look at different options. So next slide is looking at a number of options in terms of innovative option for allocating additional money, looking at the issue of health taxes, in terms of tobacco, tax on tobacco, alcohol, and sugar sweetened beverage. We did analysis. If 50%, for example, is earmarked for it, we look at diaspora remittance for your information. The diaspora remittance is as big as the government budget in Nigeria. It's an untapped resources. There are a lot of innovative ways of looking at that. We look at telecommunication tax, like for example, is only 0.3 kobo of tariff on taxes earmarked for health. We look at social investment, program. We look at certain proportion of value added tax, and then if you pull all these things together, you discover that more almost 60% of vulnerable population can be covered. We use this as example. Uh, it depends on what government want to use the money for. It could fund substantial part of our expenditure on TB, on HIV, on malaria as much as possible. So next slide. So next slide, we'll be looking at what lessons have we learned advocating for increased government funding in Nigeria. So part of the lessons that we learned first, the first lesson is that it is actually feasible. It is possible to stimulate domestic financing for health, but it is more political than technical. We have to think and work out politically. We need sustained engagement at all levels, and we have to strengthen communication nexus between the health financing actors and the Ministry of Finance actors. And at the same time, it requires understanding of the political financial and public financial management system to know how best do we budget for health. How do we ensure if we want to increase budget, how do we do it? How do we ensure that to release the money, what is the financial mechanism in place that for us to follow to be able to achieve this. So this now leads us to next slide, where we'll be talking about key recommendation, and I'll divide this into two. So there are a set of recommendations for immediate action, considering the situation we find ourselves, and how to minimize the impact of a sudden pause in the US funding flow. I think something that we have to do like yesterday is a quick assessment of potential service delivery and TA gap, technical assistance gap, from direct and indirect US funding cuts. So it's good that Nigerian government has, appropriated additional amount of money to be able to bridge this gap. But are we bridging this gap in darkness? Have we done quick assessment to see if US government through all their funding channel, if they pause the funding, what's going to be the implication of service delivery? What is going to be implication on technical assistance? And it's not only money that is coming directly from the US government. What of the money that will be coming through WHO, Gavi, and others? And we need that quick assessment. Number two, we have to look at how do we use the sector-wide approach? I'm very happy the sector-wide SWAP people are in the room. How do we use SWAP to reassign funding responsibility and try to find out the gap that will be created, who will take over those gaps? But here we are still asking government to take the lead, federal, state, and local government as well. Number three, we have to re-examine the aid delivery approach to adopt more efficient delivery mechanism. The fact that we are going to take over from donor and partner does not necessarily mean we have to do it exactly the way they are doing it. Probably we have to learn from what they are doing well. At the same time, we have to correct where things are not done very well, so that we are going to be very, very efficient. Then we have to activate the already developed sustainable financing plan for the priority programs. Most of the priority programs already have sustainable financing. If you look at malaria, TB, HIV, AIDS, they have a sustainable financing plan, exit plan, which are doing very well on the shelves, which have not been activated. So, and then we have to, because commodity constitutes huge proportion of financing of funding for program. And the good news is that the present government is looking at value chain strengthening through PIVA. So we have to activate that. So in terms of longer term recommendation, so again, we have to stimulate political appetite for improved aid investment. Like I said earlier on, it's more political than technical. We have to engage at all levels, from Mr. President, governors, and the local government, because of the local government autonomy now. Then this is now the right time to establish mechanism to actualize viable, innovative financing options. We have identified the options. A lot of analysis have been done in terms of what is the additional fiscal space they are going to create. What we need now is the political will to create a structure within the Federal Ministry of Health to look at innovative financing for health to translate to move ahead. Then I think going forward, we have to do development differently, in the sense that development assistance for health should incorporate stimulating domestic resource mobilization as part of their delivery. It is very, very important. And we have to look for at how do we ensure synergy between development assistance that is looking at health and developing a system that is looking at broader governance and economic growth. So that as we are working on, for example, tax reform, for example, how do we feature health as much as possible as beneficiary? We have to tackle wastage. There are a lot of wastages, even the little resources that government is and donors are spending on health. One important area of wastage is human resources for health. One state government in Gombe, they are doing very great job in terms of introducing biometric attendant tracking and many other wastage curbing mechanism as well. Of course, we need to deploy all the accountability framework that have been developed. We have developed accountability framework for basic care provision fund and several other initiatives. It is high time we have to deploy them. So we have to stimulate private sector investment on health as much as possible. I would like to leave you with this great reflection from very, very powerful actors in the development space. Next slide. Uh, from our own so this slide is talking about political appetite for health in action. You can see engagement between health actors and the governors of three states on one side. Chatham House looking at issue of health in details and different from typical events you have where governors just come and give a goodwill message or opening remark and leave. And you can see on the other side effective engagement with the governor of Nasarawa State there, discussing health issue, which actually translated to significant improvement in health financing for Nasarawa State. You can look at Nasarawa State spending more on equity fund, local government spending on equity fund. So before I leave the next slide, I'll leave you with great reflection from very powerful international actors in development space. One, Ngozi Okonjo-Iweala, she said, and I quote, "Africa can fund itself by mobilizing domestic resources. African leaders need to harness continent resources and rather than relying on aid." And in the words of Magda Rovalu, who is the chairperson of UAC 2030, she said, and I quote, "We need to turn the crisis into a great opportunity. We should not allow the crisis to go to waste." On that very, very optimistic note, I'd like to say thank you very much for listening.
Thank you so much, Dr. Gafar. I think I've really enjoyed listening to you, and I think that I can say same for my audience. To manage time, I'll just quickly we will move your questions to the general Q&A session during the after the panel session. And in terms of I've gotten a lot of takeaways from what you said from your very brilliant presentation in terms of defining the scale of the problem. 70% of Nigeria's um, health expenditure is actually out of pocket and oftentimes leading to catastrophic health expenditure for the individuals. But you've also spoken about where we can find opportunities in terms of speaking about looking for innovative financing mechanisms, such as the use of health taxes, sugar sweetened beverages, and the like, tobacco taxes. Talked about diaspora remittance as a huge opportunity that we are not tapping yet, telecommunications taxes, and the likes. And you've also spoke a lot around what opportunities those are in terms of doing things a bit differently from how they were. And also the beauty of being able to um, finance domestically because it's much more sustainable, it's much more equitable because everyone contributes, so it's not based on donor preferences. So I've really loved listening to you. With that said, I will transition this to the panel session that will be led by the managing partner of ACE Group, Dr. Afeez Olajire. He's the managing partner of ACE Group. He has had extensive experience working in health systems within Nigeria and the Southeast Asian subcontinent. He's done lots of work supporting governments in Kano, Bauchi, and also Sokoto in developing solutions to local problems. He has led several projects on gender, climate, health financing, and also resource mobilization. He has also served as an area owner on global vaccine delivery with the Clean Health Access Initiative, where he supported Southeast Asian Pacific countries to develop monitoring and evaluation frameworks to build up accountability and track financial aid and technical program performance. Prior to that, Afeez has also worked at Solina Health and UNICEF. He holds a master's degree in public health from the University of Ibadan. Ladies and gentlemen, Afeez Olajire.
Thanks so much, Dr. Talib. I think we've had a very good stage for this conversation, starting from the brilliant presentation and the keynote address from Dr. Gafar Alawode. Thank you so much for that very insightful presentation that we all felt we should keep listening to for the rest of the day. And thanks, Dr. Talib, for moderating that session. So now we'll move on straight into the panel proper, where I will start by introducing our esteemed league of panelists. I'll start by introducing Dr. Muntaqa Umar Sadiq, who is the National Coordinator of the Nigeria Health Sector Renewal Investment Initiative and the sector-wide approach. Dr. Muntaqa had previously served as Technical Advisor to the Minister of State for Health, where he has led major health reforms, policy development, and performance management initiatives. Dr. Muntaqa, in addition to him being the National Coordinator of the Health Sector Renewal Initiative, Dr. Muntaqa has also led a lot of domestic resource mobilization as well as fund pooling to ensure we have sufficient to power our health system in Nigeria through the initiative around Gates Foundation, PACMOU, Gavi Health System Strengthening, and the swap funding. He has held various leadership positions across Federal Ministry of Health, the Private Health Sector Alliance, the Nigeria Energy Transition Office, and the World Bank. Dr. Muntaqa holds a Master of Philosophy in Bioscience Enterprise from the University of Cambridge. He's also had an MBBS from the Great Imperial College London, as well as a BSc in Management, Finance, and Health Economics option. He's a chartered accountant. He's a chartered, yeah. So, yeah, he's a chartered alternative analyst and is currently pursuing a doctorate in public health from the London School of Hygiene and Tropical Medicine. So from there, I will transition straight into introducing Dr. Raihanah Ibrahim. Dr. Raihanah Ibrahim is the principal and the director at CIDA. He's a seasoned public health system strengthening expert. He leads the organization immunization, primary healthcare, and wraparound gender portfolio. Dr. Raihanah manages the CIDA relationship with EPI and PHC stakeholders across government agencies and development partners across levels. She has robust experience in strategic planning, innovative designs, implementation, and monitoring with a focus on health system strengthening, service delivery, and sustainability. She has provided strategic support for the development and implementation for numerous countries and state governments to unlock funding from several sources, such as the Gates Foundation multi-year PAC MOU, that she has successfully started and scaled up beyond the initial states that were enrolled on this, Gavi HSS, the full portfolio planning, and several other efforts by Dr. Raihanah Ibrahim. In addition to that, she has also been a very big voice in ensuring that the health system in Nigeria continue to be well positioned for success. And the last but not the least, I'll be introducing our third panelist, Dr. Yakubu Agada Amade, who works with the Nigeria Health Insurance Agency. Authority. Dr. Yakubu is a public health physician and health economist. He holds a medical degree from the University of Calabar. Dr. Yakubu has a diploma in public health from the London School of Hygiene and Tropical Medicine, as well as master's degree in health planning and management from the University of Maiduguri, and a master's degree in public health from the University of London. He has worked with the National Health Insurance Agency for over 2 decades and has led and served in numerous teams in the development and implementation of the agency policies and interventions, such as the NHI Standard Treatment Guideline and Referral Protocol. He contributed significantly to the 2012 and 2023 NHI's operational guideline, among several other key initiatives that he has supported. As the Director of Standards and Quality Assurance Department, He oversees the strategic purchasing for the organization, including healthcare quality. He's also a member of the African Health Economics and Policy Association and the Nigeria Institute of Management, among others. So ladies and gentlemen, esteemed participants on today's webinar, join me to welcome the three panelists to this conversation. So thank you once again. And at this point, I will be diving straight into the questions for our panelists. You make use of the Q&A chat, drop your questions, and I can assure you that our esteemed panelists will do justice into delivering quality response to all of you.
Did you get a call?
Yeah. So
No,
for that, I'll be starting my first question I'll be starting my first question. I'll be directing that to Dr. Raihanah. So Dr. Raihanah, like I've read her profile to you all, has been a very key state player in ensuring that beyond advancing the health system, there is also ensuring there are systems to improve participation from the government side beyond whatever the donor is bringing to the table. So Dr. Rai, on that note is where I'll be asking you the first question, which is for you to help us give some very brief overview of what the funding mechanism, the basket funding mechanism that you have led at multiple levels, what that is about and how this approach has been used to finance health system in Nigeria. Over to you, Dr. Raihanah.
Thank you so much, Afeez. Thanks for having me, and good day, everyone. Please confirm you can hear me.
Loud and clear, we can hear you, Dr. Raihanah.
Okay, thanks so much. So the basket fund, I'll quickly introduce the concept and actually talk about like how it worked in real life. So the basket fund was an innovative financing mechanism that was established as part of the Memorandum of Understanding that was signed between the Gates Foundation, the Aliko Dangote Foundation, and state governors. It's important for us to understand the foundations that are here and the people behind them. So that's Bill Gates, who is like at the time the richest man in the world, and Dangote, who was like the richest African man, but also like the richest man in Nigeria. It's important to note that because those voices and the people who were behind the foundations or the initiatives were critical. And why was the basket fund necessary? It's all of the issues that Dr. Gafar has mentioned. It's the fact that at the time, routine immunization coverage was really poor. And this was as far back as 2012. When it was checked, there were 6 states in Nigeria that contributed over 5% of the world's unimmunized children. And it was evident that there needed to be more political will and funding to be able to strengthen the system, but also like optimize service delivery. And so it was established that we would have a way to pull funds or pull resources for immunization. So this started out as an immunization investment, but all the other mechanisms where donors just funded and gave government money or funded activities had been happening, but that wasn't necessarily getting to the front lines. And so the basket fund mechanism was thought through. And what is that? It's essentially a joint account where the donors would put money into that account. This account was government owned, government managed. But with that trust, that government would be able to manage it with some guardrails in place. So this joint account would have Bill contribute a certain amount. That's the Bill Gates Foundation contributes a certain amount. And then the government will be required to contribute their share of the funding. And then until government contributed, then Aliko Dangote Foundation would also put its money in there. So there was some form of contingent funding, or what people would call match funding, at this time, where they would expect government to put in some amount before the second foundation would put it in its amount. But, you know, the first foundation will put in its amount first, just to kind of spur government and incentivize them to also pay their share. What was also critical about it is that it was a sliding scale. It was designed in a sliding scale, meaning that costs or funding responsibility was gradually shifted from the donors to the government over time. So if we started asking governments to pay everything all at once, it wasn't going to work. So it took a couple of years to get government to pay a higher proportion every year towards getting to 100% at the end. It was also designed based off of an estimate of what it would cost to run an efficient immunization program annually. And then that's the total sum that is then split in proportions. So I believe for most of the states, the state started with a 30% contribution, whereas both foundations were contributing 70% cumulatively. So in this case, BMGF would put in 35%, then states would be required to put in 30%, and then the Liquid Dangote Foundation will put in the balance 35%. And it was also done in a way that allowed us to put the capital expenditure, so things around buying cold chain equipment, things around infrastructure upgrades, the heavy cost items were put in the earlier years where the donors were paying more of the money, so that in the later years where it's more of operational costs for funding service delivery, funding direct vaccine deliveries to the front line, funding supervision. By then, we would have already done all the capital expenditure things, and it would be cheaper, or it would be a leaner cost for the states to be paying at that time. So that essential approach allowed states to graduate into paying that, and they had time to ultimately, get used to the idea and put measures in place to be able to fully fund their vaccination programs. Over the years, of course, that has expanded beyond vaccination programs to other maternal and child health programs. But it was critical that that mechanism be there. And because, again, it's a government account, you then need to put in a lot of financial management mechanisms that guarantee that the funds are not misappropriated, and of course do a lot of advocacy to make sure that the funds are drawn. So there were systems that were built around that I can talk a bit more about as we progress, that kept the funding to keep coming, and also ensured that the funds were being utilized for what it was meant for. I'll just pause here now in the interest of time.
Yeah, thanks a lot, Dr. And I think that's quite insightful and help all our participants or the audience to understand what the basket funding mechanism looks like. So, and my next question will still be to you on the basket funding mechanism. Like, we've seen a lot of results around how, from your explanation, how this has been able to help us move from where those states were to the new reality. So it would be good if you could share with us about your experience on some of the efficiency that you have achieved with this mechanism and the impact this mechanism have had in the implementing states where this has been done. Over to you, Dr. Raihanah.
Thanks a lot, Afeez. I wouldn't be able to talk about the efficiencies without talking about like the systems that had to be built both around the basket fund, but also how the funds being available were then used to strengthen other primary healthcare systems. So specifically, one of the things that was critical, or one of the efficiency points, was ensuring that the costs were lean and they were reasonable. You would recall from Dr. Gafar's presentation that he did mention that, like, what exactly can they sustain, and making those costs realistic. So from the get-go, because the states knew they were going to ultimately start paying for these activities, they knew that they couldn't afford to put in the things that they couldn't sustain. So large trainings or activities that wouldn't necessarily lead us to the outcomes that we wanted to see, or over bloated unit costs or frequencies. So from the beginning, there were efficiencies around costing and around where we were putting our money into, and making sure that that money ultimately led us to the outcomes that we wanted to see. So drawing that direct efficiencies around accountability. I think one of the things that people used to say is, like, it's called a basket fund, but it's the tightest basket ever woven, just because of how it was very difficult to foul for there to be leakages in the system. And why this was possible was because it's was accompanied by a tight financial management system. So before government can take money out of that account, they needed to have a work plan that's fully costed. They needed to prioritize activities by quarter and request a no objection from both foundations and other partners that it was okay to make that transaction or to spend the money. There had to be, we needed to establish a financial working group that included, now having a strengthened financial management unit within the state primary healthcare boards that were able to now do financial accounting, do bank reconciliation and all of that. And most importantly, there was also a dedicated accounts that were established at facilities, right? So in these 6 states, Bauchi, Borno, Kaduna, Kano, Sokoto, and Yobe, as early as 2014, they had all their immunization facilities, or all the facilities providing immunization had bank accounts with signatories that were clearly defined and at different levels that ensured that monies were sent directly to the front line. In many of the states, those accounts ultimately transitioned to the BHCPF accounts for facilities that ended up being earmarked for BHCPF funding. And so that's like one efficiency. By the time BHCPF and other direct facility financing mechanisms came on board, these states already had the financial management infrastructure to be able to do that. Of course, that also helped to improve the capacity of the agency and improve their PhD under one roof scores and things like that. So now talking about efficiencies around implementation or around service delivery, the basket funds that were available, the monies that were sent to facilities enabled health workers to actually go and conduct their outreaches, because now they were getting the whole amount and not, having cash leakages as it went from hand to hand from the state to the facility level. There was also improvements in vaccine availability. So in some states, we saw initially before the MOUs or before the basket fund, we saw stockouts of vaccines of 60% and higher. And ultimately, by the end of the intervention, we saw every state at less than 10% vaccine stockouts, because they had funding at the state level to actually take vaccines directly from the state to the health facilities on a monthly basis, and also for the vaccine supply chain team to optimize systems, monitor appropriately, and make sure that there was cold chain and things were flowing seamlessly. Of course, in terms of data management, LGA review meetings, data quality assurance, supportive supervision, and all of the systems across the core pillars, and not to forget demand generation as well was like a critical one, where a name-based strategy, which is now informing the identify and enumerate and vaccinate strategy, where traditional leaders were mobilized, leveraging gains from polio and all of that to improve, vaccination demand using a per child or a name-based strategy for each child. So all of these things ultimately led to significant coverage improvements. And it will be important to also just caveat that to say that varied from state to state, indicating that, for a state like Yobe, for instance, they made very tangible progress on their coverage, up to a significant doubling and tripling of their coverage numbers, but not so much in some other states. But we did see cumulatively over 100% increase in coverage within these states. But most importantly is how the states are now poised to be able to execute a lot of the other things, whether it's annual operational planning, which some states are still struggling with. As of last year, these states had a well-oiled engine to be able to implement all the reforms that we're seeing with N3 and with SWAP, because they already had many of those systems, and they also have that capacity to continue to improve and optimize their health systems accordingly. So I would say the efficiencies are both in terms of, financing and financial management, broader system pillars, but also in terms of, reaching every child or reaching every mother. And we've seen successes with scaling this to PHC, scaling this using that model. Gavi MOUs went to 8 additional states, using some of the core principles of the MOU. And of course, the foundations also expanded the intervention or the approach to Chad and Niger as well.
Dr. Raihanah, that's very heavy and a lot of lessons to be picked from that. And we'll come back to you very shortly. I think my next question will go to Dr. Agada Amade from the NHIA. And I'm directing this question to him because from everything you've said, it seems the MOU, the basket funding approach has worked very well for everything we've seen on the immunization and PhD side. But there is also the big elephant in the room, which are some of these issues around HIV, AIDS, tuberculosis. We know in countries with some robust system in place and robust health insurance coverage, most of the care for an HIV patient, a tuberculosis patient are catered for from the health insurance. But on contrast to that, in Nigeria, what we have majorly is people have to rely heavily on donor funding, like a USAID, the APIN, the IHBN, to assess basic care for basic treatment for HIV and AIDS that require people to actually be on some medication and increase testing. So it would be good to hear from you, Dr. Yakubu. What is NHIA doing to improve the number of, to increase the number of coverage, people that are currently enrolled on the NHIA or the NHIA scheme? And yeah, what are the novel approach that you are bringing in to make sure we have more people enrolled to benefit from the health insurance scheme? Over to you, Dr. Yakubu.
Thank you very much, Afeez. So, can you hear me?
Loud and clear, sir.
Okay. So I'd like to start by talking about the low national coverage for health insurance. We have issues of high out-of-pocket payment. This is because a significant portion of the Nigerians are not enrolled on health insurance. And this is disturbing because we would have loved more Nigerians to be enrolled. As at December of last year, we're talking of figures of about 9% to 10% of Nigerians enrolled on health insurance. This is not good enough. We are hoping that, but on a positive note is that last year we were able to bring in about 2 million Nigerians on board through the Basic Healthcare Provision Fund, the State Social Health Insurance Agency, and the NHIA programs. We also are grappling with the issue of limited awareness. Many Nigerians are unaware of the benefit of health insurance. And this has led to low enrollment figures that we're having. Now, coupled with this is the large informal sector of challenges that we have in the country, and this is to do with the way the country is. Most of the population in the region of up to 70% are in the informal sector. And if you understand health insurance enrollment is more difficult, and enforcing mandatory health insurance is more difficult with the informal sector. We have issues of economic barriers where poverty is rife. We know the Nigerian Lancet Commission studies and even report from the National Bureau of Statistics specifies the number of Nigerian, high percentage of Nigeria in multi-dimensional poverty. This makes it challenging for many to be able to afford a health insurance premium. Again, is the infrastructure gap, inadequate healthcare facilities and services. We talk about quality of care every day. This demarcates health insurance for those who are already enrolled, and it becomes more difficult to convince people to enroll. But having said all that, there's also the benefit that we have, and Afeez has asked that what are we doing about making sure that more people are enrolled on this program.
I don't lie to
We
yourself.
have the benefit of the 2022 NHIA Act, which mandate health insurance for all Nigerians and legal residents. This is aimed to increase coverage, and we are hoping that we will be able to, increase the coverage by mandate. But like I always say, it's one thing to mandate, it's one thing to actually get people enrolled, where there's also a level of what is the quality of care you provide, how easy is it to enroll, and then what things have you made available for people to easily have access to, and that's what part of what we're doing. There is a vulnerable group fund, which is also provided for in the NHIA Act of 2022. That particular fund is supposed to be a game changer, because the idea is from the Lancet report, the high percentage of Nigerians that are that are vulnerable are supposed to be paid for from that fund. The VGF is underway and is supposed to support the healthcare need. We are working with the parliamentarians, the members of National Assembly, to ensure that it is adequately funded. There was some fund provided for it last year. That is 2022 budget, which we are currently running. We are hoping that it will be increased. There is the Basic Healthcare Provision Fund, the NHIA Gateway, which is already being operated. Over 2 million, 2.6 million or so, about that figure is already, Nigerians are already being covered. That provides for 1% of the consolidated fund. The revenue, the federal government revenue, the one accruable to federal government, we are paying for that, and we're able to use the state social health insurance agencies to provide for those who are vulnerable populations in the state. We are collaborating with stakeholders to be able to also increase this and see what we can do concerning expanding health insurance in Nigeria. Public awareness campaign is very important, and we are calling on all Nigerians and all CSOs and all bodies who are able to play in this field to be able to come, because as Dr. Gafar said in the opening, the global health space is changing. We are seeing comments and decisions coming from the US. We don't know when it will come from Europe. And it is time for us to start thinking sustainability. And what is the most sustainable way of financing the health system in Nigeria? We must think of indigenous kind of mechanisms to use. We must think out of the box. It's no longer going to be the usual thing. We must think more money for health. We must think more health for the money that we have. It's beyond just government voting money, but how are we going to be efficient with the much that we have to be able to do that? We need to convince Nigerians that when they enroll in health insurance, they can get the benefit. We are currently working on the operational guideline to make it more robust. And to talk about HIV/AIDS, why not? The common reason why HIV/AIDS and TB are not currently being covered full in terms of the medicine, and let me be clear about this, the medicines, is because as at the time the health insurance was taken off in Nigeria, there were so many donor programs that were providing free ARTs. And because of that, it will be like double billing or double funding for government or government agency to begin to pay for drugs for HIV/AIDS. But it's becoming obvious that there is donor apathy in that area. It's becoming obvious that policies of states are changing. And it is time for us to begin to think. Even the vertical programs that are mentioned we need to begin to collapse them into more sustainable units that can actually provide for the funding of these diseases. There are diseases that are with us. Unfortunately, the disease burden are higher in countries like our own, low and middle income countries, and also Nigeria particularly, where we have the population and the burden is high. Then the per capita for those diseases are going to be higher in Nigeria. So these are some of the issues that we are looking at. We are repositioning, we are driving, we are thinking of innovative ideas like like an insurance catastrophic health fund, where we'll be able to pay for such diseases like sickle cell disease, which we know is a problem of Nigeria, and the black race. We're thinking of end-stage renal disease. How do we manage it? How do we pay for organ transplant? Those are the kind of diseases that if you put on the pool, ideally, they are capable of causing catastrophe to your pool. So how do we have the kind of funds that will be able to pay for that? We're thinking of cancers, and of course, TB and malaria, TB, HIV/AIDS, and family planning are things that we're looking at, because like we know, these things the funding for them are drying up. And we have to find a kind of interventions that are homegrown that will be able to address such issues. So this is where we are currently. Back to you.
Thank you so much. Thank you so much, Dr. Yakubu. I think one thing that has been quite enlightening every panelist speech is we are approaching all of this from an opportunity perspective rather than highlighting what the problems are. And I completely agree with you with how you are drawing the intersection between generating demand for increased enrollment into NHIA, as well as making sure that is colliding with some support in ensuring that the primary healthcare system is strong, the entire healthcare system is strong, such that when you then generate the demand, when people get to the health facility, the state of the facility where they are going to assess their benefits is actually equipped enough to give the value that they want, that they desire. So I completely agree with you. And I'm glad that you've also touched upon what should have been my next question on how positive we are that Nigeria could at some point absorb the service delivery cost for HIV. Interesting to hear all of those recommendations, what you're doing at NHIA, and for sure, I'm going to come back to you soon. My next question will be going to Dr. Muntaqa, who is ably represented by Dr. Ganavua. And to set the stage for that conversation, because the swap office looks like the engine room of all of these resources harmonization effort that we are looking at. So my question to Dr. Ganavua, who is representing Dr. Muntaqa, would be for you to, first thing is probably to enlighten everyone on this webinar on what the swap office is about and how swap is being used to increase coordination in the health system space. Over to you, Dr. Ganavua, and please kindly correct me if the way I pronounce the name is not correct, so I could fine-tune that going forward. Over to you.
Hi, yes, good evening. My name is Olajire Aganvo, and I lead resource coordination in the sector-wide coordination office. And thank you very much. I am representing Dr. Muntaqa, who is unavoidably absent here. Please confirm if you can hear me.
We can hear you loud and clear, and thanks for the correction about the pronunciation of your name.
Thank you so much. Unfortunately, I won't be able to turn on my video. I am in a meeting, so I just had to sit on the side. Thank you everyone also for this very enlightening webinar, and thank you for the question. The sector-wide approach, like we always like to mention and start, is that it's not new. It is not a program. It is not a project. It is what it is in its name, an approach. And what it aims to do is that over time, what have we been doing differently? We have been ridden with fragmentation in our system, multiple donor systems, a lot of challenges, inefficiencies. If I could ask everybody in the room to tell me one challenge that they have in the health sector, I'm sure everybody has one, can realize one challenge or another. whether it's inadequate funding or even inefficiency in the funding schemes. So the sector-wide, through the sector-wide coordination office, it is a mechanism that is working to institute Mr. President's desire to have a renewed sector approach to the health sector. This is all grounded in what we call a compact, a health sector compact, where the government itself has set government priorities, included development partners, private sector and the state, and even the CSOs to have a joint accountability mechanism to be able to own our results and drive our priorities for the health sector. So it is in essence going to have a more coordinated approach to delivering health systems. I think I had gotten your question right, but then I'm quite interested in, I think, a bit of what Dr. Gafar had shared in terms of navigating the funding shift, especially with the US funding gap. It is no news right now that US has pulled a lot of the funding out of the health sector. And rightly stated by Dr. Gafar, US itself provides about 1/3 of the donor landscape for the health sector in Nigeria. However, no matter how big that is, it is still within the 11% of funding that goes to the health sector, aside from government funding, out-of-pocket funding, and private sector funding. Moving forward, we have, through the sphere of the coordinating minister, have actually done an analysis to review the essence of this gap and what it means to the Nigerian sector. So we are not blind to this fact, and then we're working to mitigate some of the effects of that. I think I'm just going to stop there so that I don't take so much of the time. Over.
Yeah, thank you so much. Thank you so much, Dr. Alawode. Yeah, so thanks for also clarifying the approach around the goal of the sector-wide approach, which is one plan, one budget, and one robust health system, and also reminding us that it's nothing new. It's a way of ensuring that there is a coordinated effort to addressing the health need and ensuring that we are having a sustainable homemade solution, which is actually the theme of what this convention is supposed to address. So the next question I will be asking will still be to you. Dr. Raihanah, Dr. Gafar had both mentioned a lot around the private sector involvement. How key private sector is into driving the funding mechanism that we need if we want to mobilize our own resources domestically. And looking at the mandate of SWAP and all of the already exceptional role you are playing, it would be good to hear from you how SWAP encourage further participation from the private sector, especially at this critical time. Dr. Ra has mentioned a lot about the Gates Foundation, the Aliko Dangote Foundation, and a lot of private sector player that has brought a lot of resources into, committed a lot of resources into strengthening our healthcare system. So my question to you is, how more can you think private sector can play a role? And what is sector-wide approach office doing to improve that participation from the private sector? Over to you.
Thank you so much. Yes, the private sector does play a huge part in both funding and also access to healthcare in the Nigerian space. Within the SWAP mechanism, what we drive within a coordinated system, like you rightly mentioned, are the pillars of the one conversation through engineered through technical working groups that sought to be the engine room of key government priorities, whether it's in maternal and child health, or it is in M&E, or more recently, even the HPV and malaria space. The second pillar is around having a one plan, one vision for the country, setting priorities for the country. We do have that under the Nigeria Health Sector Renewal Investment Initiative, and more recently, even the Health Sector Strategic Blueprints, where all the states within, for the first time, have come together to be able to finalize on their annual operating plans, to be able to be that leading tool for the state priorities keyed into the health sector blueprint. We also have the One Budget, which aims to provide visibility around health financing, visibility about resources, but not just visibility, but how do we consolidate the financing and make for efficient use of those financing. So the private sector, as you rightly mentioned, we do coordinate with them, especially in the areas of regulation through the one conversation as well as the financing. We know that recently we have done a resource mapping and resource tracking to be able to understand the fiscal space of the country. The resource mapping included donor funding that have been committed into the country, as well as the government funding. The next layer really is the private sector. Organizations and philanthropies like the Dangote Foundation, like Tony Eluminu, Mastercard, a number of these organizations who have even coordinated themselves within what they call the Private Sector Health Alliance, has also been an entry point for us. Because these funding we are able to use, these are homegrown funds, and we're able to reallocate or even redirect the conversation to what we can mitigate internally. I know that you may have heard about some initiatives like that the private sector is doing, like adopt a PHC or even cost cover for insurance premiums for a number of people within the sector. These are still within the conversations of the sector-wide in driving one conversation and improving the health situation for the country.
Thank you very much. I think that's clear and good to know that all the participants could be rest assured that the vision around bringing private sector to be a key player, because we've seen from other countries how private sector plays a critical role in driving the economy from the lens of the health to every bit of the infrastructure, IT, and all of that. So good, the swap is already helping to do that heavy lifting. And from where you landed, will make me go back to Dr. Raihanah. So Dr. Raihanah, we've done a lot of exceptional work. You've been able to upscale what the PHC basket funding mechanism is from just Kano State to 6 states and to 8 states. And a lot of results, over 100% coverage is not something a lot of countries has been able to crack. So with all of those exceptional work and results that you, together with your organization, has been able to achieve, it would be good to, if you could share with us, what are those things that you think work well that could be responsible for some of these success that you've recorded? And if you think the basket funding mechanism, if we are thinking about scaling them up to other states, what are the things we should be mindful of? And what are the lessons that we have learned that will help us guide some future scale up of the PHC basket funding mechanism? And this because your explanation already clearly shows the significant result this has. And as we look to strengthen the home-based solution, it's good to hear from you what are the lessons we've learned, what has worked well, and what we should be noting down as we look to scale this up beyond the 8 states that are currently implementing it. Over to you, Dr. Raihanah.
Lots, Afeez. I think to caveat that, first, it's important to say that one of the major feats that this thing achieved was that for once, people felt comfortable that they could put money in government accounts and that it would be utilized for what it's earmarked for, like with accountability across every level, to the point that even where mismanagement is identified, so maybe a facility does not conduct the outreaches, there are measures to either recover the funds or to have them, still implement the activity at no additional cost. But that trust obviously came with like I said earlier, certain guardrails that ensured that those things would happen. I'll say in terms of why this was successful, one of the things was, yes, we had an MOU that backed it and it was signed. One additional layer that needed to be included was actually having dedicated budget lines for the RI and ultimately later for PHC. So beyond, we're funding SPHCMB or we're funding we're renovating facilities and all the normal things that states put in their health budget, there's a dedicated line that is coming from like a special fund specifically for that activity. So I saw in the comments something around and from Dr. Alawode's conversation around, having like a dedicated budget line for health security, for instance, in Kano. So that's like one of the things that was essential. So it's in the budget every year. It's permanently in the template. So it's something they know they have to allocate funds to, and would typically not be cut. Right. But there's a long line between having the budget line or having it budgeted to actually having it released, right? Which is one of the bigger issues that we have in the country. So that also was going to show up. But the things that made that bridge to be collapsed or to be crossed successfully is one, the voices of the people that were in there, right? So again, this is an MOU that is signed between a governor at the highest levels, and these two individuals who are super committed. Every year they would meet twice a year, the governors and the principals of these foundations to actually discuss and say, how are we all doing on our commitments? And it was something that they all prioritized. So that high level commitment, high level and those voices being very clear and very loud. I think the fact that we also had a balance. So we had Bill, who is like the typical foreign aid provider from a donor perspective, but also a local, a Nigerian, a northerner, who was the one that was kind of, so there was some sort of good cop, bad cop dynamic going on there that ensured that, there's a local trusted person in the mix that it also has like personal and professional relationships with these governors that allows, so there's that political capital that the people involved have that ensure that it's done. All of that still needed to be built on with advocacy. See that governors would want to pay that money before they had the meeting, but also there were a series of follow-ups. So everything that Gafar said around the people on the technical side, they need to understand the political side. They need to understand what a governor is or a political leader is solving and how this will ultimately make them look good as an achievement or as a leader. How do you advocate and communicate to them what the benefits are? This is not building a road. This is not building a hospital. This is paying for the operational activities that will ultimately translate to health. So creative ways of advocacy and making sure that that prioritization is sustained, even when it's not a physical outcome. And how do you tie that to how do you put political value behind that to be able to get sustained political will from the government was critical. I'd also talked earlier about, the lean and efficient costing that needed to go into that. So it was actually realistic cost. So it wasn't a model that is, the Ferrari. It's really thinking about what's the basic of the basic costs and how do we make sure we sustain that. So this was not the time for doing things like, oh, we're going to do drone deliveries for vaccines, for example. It's the basic thing. We need a car, we need it fueled, we need it to take vaccines from point A to point B, and it's working. So it's the simple critical things that needed to be financed and those things that are actually sustainable. I think the healthy rivalry between governors. So beyond, their one-on-one meetings with the principals, there was also like interactions between states and also involvement of the Nigeria Governors Forum. So that way you're able, nobody wants to be called out, right? Everyone wants to perform well and be talked about positively. So I think that healthy rivalry and figuring out the right incentive that motivates political leaders to fully participate and fund their programs was also very critical in the success. And of course, within all of this is all of the technical support or the capacity building that was behind it, right? Whether it's capacity for the finance team of the board to be able to develop disbursement schedules and actually send money to the facilities, confirm that the money got there, confirm that, validate the retirements that are coming from the facility, or it's the one you're giving the ESs and the commissioners to be able to advocate for release of the funds, or all of the other systems that were built around strengthening technical and leadership capacity of the people that were implementing the program were all critical to getting this done. Now, in terms of scale, I think it's important to note that what scale up means can be different. And we've seen the MOU in using differentiated approaches to scale, right? So for instance, in the Gavi MOUs, they use the same financial management principles and a lot of the other interventions, but their focus was on HR. And that's one, I would say, one of the drawbacks of the MOU, right? And that's something that the Gavi MOU built on, which is we need to invest in HR. The basket fund and the one that was done in the BMGF states did not focus a lot on HR. And we know that recruitment and salaries and other HR costs is one of the places that states struggle and is the elephant in the room oftentimes, but we often leave it to government to do on its own. So I think with the Gavi MOUs, there was thinking around a sliding scale for HRH, which is also giving a lot of learnings that I know that the broader NPHCDA and N3 helped workforce optimization is also learning from to be able to scale that. So when we say scale, it's not really just lifting everything, but it's actually thinking about what the beneficial approaches, principles, and methods are, and contextualizing it for the needs of the specific use case that we want to apply it to. I would say if other states are to take this up, we need to think about what are those local voices that we need to have in place. What is that enabling environment and the framework? What can the state afford? So Dr. Gafar talked about expenditure review, fiscal space analysis. What can the state afford in the long run? But most importantly, how much will it cost? Because oftentimes we say they're not spending, or they're not releasing. But a lot of them don't even know how much they require to actually improve health in their respective states. So significant costing and being clear on what you're asking for, but also not asking for that in aliquot. So right now, HIV is asking for something, TB is asking for something, immunization, everybody's asking for something separately, and it all doesn't come together. So I would say integration, but also thinking about, having a clear cost and a clear ask for what it is. And I would say, let's use our local voices. Let's use high net worth individuals that are local and that have influence. We don't have to rely on on the external development sector to do this for us. We can use private individuals who have high net worth. We can use advocates, even just to say that I think the Nigeria Governor Spouses Forum is also one critical one, and like governors' wives also have a lot of political capital that we can leverage. And of course, ensuring that at the end of the day, the design is practical. It's like you can't expect a state to just suddenly start spending what they were not spending last year, this year, right? So what is that gradual journey that gets us there? And I see in the comments someone also talked about like a roadmap or a journey to actually getting sustainable. But I would always end or caveat it by saying, when we say sustainability, we need to also think about creative ways of defining what sustainability means. And making sure that it's truly local and it's what we can actually keep doing and keep doing well, and that it's ultimately leading us to the outcome that we want to see. And at the end of the day, it's really about the value that we can get from every naira, and less about just expanding the amount of naira that we need. Over.
Dr. Rai, it's good. I love where you landed around efficiency, which is not just about throwing the money on the table. There's also a lot of value in ensuring that the funds are properly utilized. And that would make me direct my next question to Dr. Olajire from the swap office. Recently, we've seen a lot of transformative initiative from the swap office. One of them is the MAMI initiative. MAMI is the maternal mortality reduction innovation initiative, right? And what MAMI look to do is how we can test the power of coordination, which is the big goal of the swap office in the first place, to bring all the key stakeholders from the CSO to the LGA to the state level to the federal level, bring all of that together and use that to harmonize the maternal and newborn care efforts to reduce our endemic maternal mortality. That is already a big problem in Nigeria. That's a conversation for another day. So as we bring all of these two people together, we know this is like one of a kind. This is not something that we've had to do in a very long time. So while we are trying to bring all of these key stakeholders in place, knowing that everybody already has some diverse direction of how they like to go, are there challenges that you foresee in getting this coordination done, knowing that there will be many voices in the room and there will be a lot of need for intentional efforts to mute the echo, because there'll be a lot of people in the room now that we are trying to implement this MAMI strategy? And what are the mechanisms that SOCOM is already putting in place to mitigate some of the issues that could come up due to the large amount of stakeholders that we are bringing in to use the catalytic MAMI approach to crash our maternal mortality, which is one of the biggest mandates of the Honorable Coordinating Minister for Health and the President of the Federal Republic of Nigeria. Over to you, Dr. Alawode.
Thank you so much. So central to the sector-wide is coordination. And for that to happen, there needs to be a government-led approach, whether it is MAMI or any other sector, like the AIDS, TB, and malaria, or any other disease, that might require some sort of push to be able to help with the health indices. So the key message is the coordination within the sector, which is why the sector-wide really was a vehicle that the president and coordinating minister thought to use that. Another thing is the political will. The government is willing and is ready, except a government leaves its responsibilities to multiple stakeholders. That is when it will be drawn left, right, and center. But when the government is central to the discussions, pulling it and coordinating these efforts, like you rightly mentioned, MAMI has a number of stakeholders, and we're looking at several layers of delays, whether it's delay in accessing healthcare or delay in transporting a pregnant woman or neonate to the nearest health facility, or even the delay in providing the health service, whether it's a supply side problem, or even what we've added right now is the delay in coordination. There are so many systems that are put in place to be able to address these delays, whether it's the demand side using the insurance, or the transportation using the NEMSIS or the SEMSAS, or supply side from the primary health care. But most importantly, the coordination in making sure that these channels speak to each other is what we are putting in place. And more importantly, I think I must have mentioned that having government central to this, setting the priorities and leading this is what we would make us stand our foot and lead the effort in coordinated efforts of not just the MAMI program, but also every other health intervention that is being driven by the coordinating minister. Over.
Yeah, thank you very much. And yeah, I think there is no better place to, it's as if SWAP saw it coming, that there will be some reduction in our fiscal space to have come at this very great time to help us ensure that we are harmonizing all of these resources and strengthening the coordination. And while talking about MAMI, I think that will make me direct my next question to Dr. Yakubu. Recently, Nigeria jubilated after reading the news that the cesarean session will not be free. There is also going to be some subsidized care for people that are struggling with chronic diseases, the kidney disease, and some other chronic diseases. And with that in mind, we also understand some of the limitation. A country with over 200 million people, we have just 10 health facilities that are going to be implementing these. Looking at things from two sides, one is the access side, two is the sustainability side. What is NHIA going to do to address issue around access? We have just 10 health facilities that will be implementing the dialysis, the social dialysis care, and also the free CS. We know how that's enrolling that and some of the internal workings. So it will be good to hear from you. I think so. My question to you will be in three phases. It would be good if I could get some summary from you in less than 3 to 4 minutes. One is the free CS. Where are we with implementing that, and when is that likely to roll out? The second thing is the subsidized dialysis plan? How is that going to be? Are there plans to scale that up beyond the 10 teaching hospitals that are currently going to be rolling that out? And the third thing is, what's the sustainability plan to consolidate on all of the wins we definitely get from these two brilliant initiatives that is being championed by the federal government and executed by your esteemed MPA? So over to you, Dr. Yakubu, on those three pieces of question. Over.
Thank you very much, Afeez. Let's see what we can do in 3 to 4 minutes. I don't know how that will work, but I will just give him my best shot. And now we're talking about the free CSO program. We have earlier done the free obstetric fistula program, which we had rolled out. It's actually not, I don't know, maybe you were talking about the dialysis in the 10 centers. We have several facilities already accredited. And we have made a lot of stride with the initiative, the free cesarean session. I would rather love to call it the government funded CS sessions, because as a health economist, I don't think any service is free. And then there is the issue of human rights that makes health a human right issue. And every Nigerian, everybody in the world is supposed to have access to quality health care. So these are issues that have come up, and quickly talk about the free CS that we have commenced actually in a lot of centers in Nigeria, and in many of the zones in all the 6 geopolitical, as we speak, people are accessing that service already. They're able to go to hospital with emergency and have emergency CS done. Unfortunately, in our client, like I said at the beginning, issue of awareness of programs are always an issue, and that's where I call on all of us that are present in this webinar to be able to go out there and make people aware that government is actually doing programs. Issues of pre-eclampsia, eclampsia, and other conditions that can increase the maternal mortality and morbidity are being addressed already as we speak. It will be good to go to our website soon to be able to access the facilities that are already accredited to provide these services. So we also have the subsidized dialysis program. Before this time, we had already started what we call the NHIA Health Insurance Catastrophic Health Fund. And that fund was supposed to take, like I said earlier, dialysis, which is part of the management, what they call the replacement therapy for end-stage renal disease. Dialysis is one of them, and then the other one is renal transplant. So the government has made the bold, pronouncement of taking up to 80% of the cost of dialysis away. I have done a lot of researches concerning dialysis, and from the researches, the pool might not be able to afford care for dialysis. So the issue of budget impact analysis and affordability comes in there. It is good that the government has realized this and they've made the pronouncement. So the pronouncement is around the consumables for dialysis, making them free in the centers of excellence across the geopolitical zone. If you look at the costing of dialysis, apart from personnel, the other cost driver will be around consumables like dialyzers, the water that is used, and all that. And so these are issues that the government is addressing frontally. We are also at NHI thinking of preventive healthcare integration. It is very important for people with chronic renal disease to be treated appropriately through whatever means to ensure that they don't end up in end-stage renal disease. that now becomes a big problem. People with hypertension, people with diabetes are particularly prone to chronic renal disease and eventually end-stage renal disease. How you manage your hypertension and diabetes is very key. So I've spoken about the dedicated funding stream, which we were thinking of. And if we have that, the idea is if we have that fund, which will also care for cancer and sickle cell disease, we'll be able to pay for people to even have up to their renal transplant done, the number of people who the fund can take care of. We need to look at expansion of the infrastructure, which the Ministry of Health is already doing. We need to have the cost management of efficiency where NHIA coming. We have tariff since the beginning of this day, since morning I've been working and I've been anchoring meetings around having a new tariff for the NHIA that can stimulate supply of quality healthcare. And that's what I've done until I've joined this meeting this afternoon. There's the issue of public-private partnership, yes. So that is also very key to how we can advance this payment for dialysis care, and also the free CS. For now, the CMONC and the MAMI program is, we're looking more at the government facilities, but with time has spread. And due to locations, there's like NHI usually do, will be engaging the private providers, will be engaging private companies to also be involved. For the funding, the NHIA Health Insurance Fund, we're looking at also bringing in private donor outfits and private companies and philanthropists to be able to donate into that fund that will be used. NHIA return on investment will also be put into there, apart from the government investment, to have that robust financing and sustainable financing platform that can be used to drive this dialysis and free CS, or like I say, government and donor provided cesarean section, not only cesarean section, but treatment of those kind of diseases that can lead to increased maternal death and morbidity. Thank you very much, Aziz.
Thank you very much. And that's quite insightful. And yeah, good to see the amazing work NHI is doing to cushion all of this and ensure that these are not just one-off win, but more of a sustainable win. So in the interest of time, I'll try and just bring all of this together and take some of the participants as asked. But before I do that, it would be good to hear from the swap office. One thing that has been mentioned repeatedly on today's conversation is the need to minimize stage, maximize efficiency. The physical space is shrinking, the population is growing, the resources are not there as much as we would have desired. What is swap office? How is swap office thinking of addressing all of this, especially because now we know that no external body is coming to help us. We have to improvise a local solution, our own based solution to solve our problem. So what challenge do swap office foresee with this, and how are they planning to address it? That's in very few seconds. Thank you.
Thank you very much. Yes. In terms of financing, yes, there are a lot of inefficiencies within the system that we hope to address. There's a lot of duplication and fragmentation, which causes for wastage. So your question really is, how do we, first of all, plug these leakages? And then secondly, how do we now mobilize internally to produce more financing for the health sector? So it's a matter of both more money for health and more health for money. I think I heard one of the other speakers say that. you would know that the 2025 budget is out and there's a case for an increased funding. I know that it's not yet met the Abuja declaration, but it is moving. Nigeria is a federation, and we're working with a number of sub-nationals also to increase their budget allocations for health internally. I really did like the presentation that Dr. Gafar gave, with a lot of innovative ways to improving and increasing the domestic resourcing within the space. We are working hand in hand with the Health Financing Division of the Ministry of Health to be able to make some of these things come to play in terms of providing innovative financing for the health space, also looking beyond government systems, but also reducing the burden on the payer for less out of pocket. But more especially, how do we now efficiently use what we have in terms of allocative efficiency? The US funding has been a big blow. We are grateful to the US government that has provided funding for the AIDS, TB, and malaria space. But right now, it has presented us with an opportunity to look inward and redesign our process, not to only be sustainable, but also to be efficient. We would not be using their systems in terms of what can be done, but has provided an opportunity for integration and for harmonization. How can we use what would be the best buy for the Naira right now using our systems? How can we leverage on already established excellent programs within the MPHCD, the NHI, and a number of parastatals to provide better health services? Areas around task shifting and task sharing, reducing the multiplications, plugging some of those leaks, our internal conversations and pragmatic ways that we are working at the SWAP office and the Ministry of Health to be able to curb wastages, but also push for an increased funding within the government space as well as innovative financing spaces. Over.
Thank you so much. I think that's well loaded and all spot on. So I will try and summarize some of the key points I've heard. And yeah, the department should not worry. We'll still be sending sentences of what this is about and how you could access all of the resources that have been discussed. So for this conversation, I think it's been quite insightful listening to all of our panelists. I'm still going to pose some of the questions that the participants had asked, but overall, I think it's good to hear from you all the importance of having some realistic costing to ensure that our costing as feasible as possible. And while we are looking to develop our own home-based solution, we are also costing what is realistic and looking at how to get efficiency from the little resources that we have. The need for coordination has been stressed and emphasized by everybody. And I think that's something we all need to take home and see why we need to strengthen our coordination and ensure that we are speaking with one voice, we are having one plan, and we are working, all working for the country and with the country, but we are not working like we are supporting an outsider. The need for transparency is key. We need to integrate if we actually want to achieve efficiency and work with the domestic resources that we have. There need to be some strong advocates for increased political will and readiness. There need to be some awareness and communication. There is a lot going on at NHI, the SWAP office, all of the organizations, UHC. We need to be a change agent that go around and let people know the initiative, and this is how you can benefit from that. Because this service would not be given to themselves. Somebody needs to drive the demand for them. For us to minimize duplication, that has been well stressed. And in minimizing duplication is really to ensure that there is a robust plan and every key stakeholder and player in this space is being pulled towards aligning what they plan to do to what is the big plan of the country. And thankfully, we have SWAP office now championing that effort. There is need for improved allocation. There is an Abuja declaration of 2001 where there should be at least 15% contribution to health by all the states. States are at varying level of implementing that. But for the ones implementing, what I want us to all remember is the difference between you allocating and you releasing the funds. So as we advocate for advocacy, we should also support our respective states during our advocacy visit to ensure that those funds are actually being released and allocation translates into release and release translates into some transparent usage of those funds and minimizing the leakages population is increasing, fiscal space is shrinking. We need to ensure that we are getting the biggest value for money, having a lot of advocacy to the private sector to help us drive all of these increased awareness as well as resource population effort that we hope to have. So all of these are said, and I know a lot more has been mentioned. Dr. Rai said a lot around how we need to be intentional and strategic about representing the states and not just giving them resources, but actually supporting them to have a plan that is practical and that will help them get the desired results in the scheme of what our health priorities are about. So on the next phase of this conversation, I'm just going to pick in one question each for each of the panelists. When I ask you the question and you answer, at the end of that, it will be good for you to give us one take-home word. I want everyone that participated in this webinar to go home with. The fact that we have over 100 people joining this, we've gone over time, their CES shows how well people have enjoyed listening to you and picking from lots of the insight that you've dropped. And we all feel blessed to be part of this. On a lighter note, I will add this to my CV that I've been able to facilitate a league of these esteemed panelists. So I'll be asking the question and I will be directing them to each of the panelists as well as our keynote speaker. And as you do that, please help drop the last thing that you think we all need to go with. So the first question I'll be asking, I'll be directing that to Dr. Gafar Alawode. And someone asked that if the private sector choose to prioritize health, especially in its CSR, the social responsibility, corporate social responsibility, are there existing initiative or policy that could incentivize them? I think that question would be to Dr. Gafar. So Dr. Gafar, over to you to answer that question and tell us one parting word that we all need to go with.
Oh, okay, thank you very much. So I think with regards to the private sector engagement, so one of the challenges with private sector engagement is fragmented CSR here and there, and with a lot of inefficiency and everything. I think one major opportunity that we've had recently is the Private Sector Health Alliance that has been able to pull private resources together towards channeling into towards health investment. And that's been a very, very efficient and a very effective approach. I know at the federal government, state government level, there are a lot of private sector policy, but one which I know is very practical, is working, is what the Private Sector Health Alliance is doing, and which private sector could key into to be able to pull the money and ensure we spend it efficiently. With regards to one parting word, what I just want to emphasize is that we should see what is happening as a clarion call, as for an opportunity for us to do different things. They at the same time do things differently when it comes to health financing. Everything that we have known, all the sustainable finance initiative for program areas that we've developed in the last 10 years, let's try as much as possible to put them into action so that we'll be able to generate domestic resources. It's actually feasible. The fiscal space is there. We just have to translate it to action. Thank you very much.
Yeah, thank you very much for succinctly putting that, Dr. Gafar. So my next question will be to Dr. Raihanah. You have dozens of questions, and just to reassure our participants that most of these questions will also be sent to the panelists, and stay tuned to all of the pages to ensure that you can get answers. We'll answer them routinely, week in, week out, on all our platforms, as well as sending it to our webinar, our newsletters, so you don't miss on any of the conversation. So the next question will be to Dr. Raihanah. There has been a lot of question around the efficiency of the basket funding mechanism. And the question that is being asked here is, what, in the face of the LGA autonomy that we have had, where there is now the fund for the LGA now goes straight to the LGA, and most of these MOU are being signed by states. So the question to you is really, how are we rethinking that, and what are the things that we need to put in place? And as you answer that, it will be good to hear the word you want us to all go home with and bring to our next edition of this webinar as we navigate these complexities. Over to you, Dr. Raihanah.
Thanks, Afeez. I'd like to say that I'm just a measly partner in all of these discussions on what LG autonomy means for our health sector. And so I would I would defer on like categorically responding on, what it should look like. What I can say though is from some of the conversations that are going on what it means and even what swap means for states directly signing MOUs. There's conversations around what the future might look like if states were still looking to implement this kind of model. And some of it is really around expanding who is signatory to these MOUs and who is contributing what based on the roles that they have, and what is backed by law. So, for instance, conversation is if you do want to sign an MOU with a state, national needs to be involved, not just from an FYI basis, but potentially be a signatory to that agreement. And that's something that, for instance, in the Gavi MOUs, it was signed with the MOH, not even directly with the states, right? In Chad and Niger as well, the MOUs are at a national level. And not at the state level. Of course, it then gets a bit more complicated in Nigeria when we now talk about LG autonomy. And I would say we then need to think about the LGA as a constituency, and as people who should also contribute, both from a political representation or participation standpoint, but also from a signatory and having obligations or funding responsibility that they're also making. I think if we reframed it in that way, and I would look to Dr. Gafar and Adzi to also weigh in, that might actually be solving the issues we have with, them not being mandated to finance things, because then they would be signatory to something, they would have a say in what's happening, but they would also kind of be incentivized to put their money in a pool, and that would actually ensure that we're able to contribute from across the different levels for something as complex as health, which is on a concurrent list and has many different players involved. And primary healthcare, especially, we cannot do such investments anymore without actively bringing in the LGA into it as active participants, if not even the primary holders of such agreements. Thank you.
Yeah, thank you. So parting word for us, Dr. Raihanah.
I would say my parting word is really around being flexible and adaptable, and also believing in what is possible, borrowing from some of the things we've said about HIV. One of the projects we've been supporting states to do is incorporating sustainability into HIV, so that HIV is not a standalone program that is implemented majorly by donors, but brought into the PHC system. And that is both in terms of, extending it into things like BHCPF, or at the very least mobilizing domestic resources within a state, and doing that in a structured way. So before the USAID Stop Work Order, we were doing things around, HIV trust funds, so setting up HIV trust funds in the state, thinking about what works for each state. And we're doing this in about 5 states, and each state had a different definition of what their sustainability priorities would be. And so my parting word is really flexibility and adaptability, but most importantly, contextualizing to states, because yes, we're talking about local solutions in Nigeria, but what is local for Kano is very different from what is a local solution for Kwara. And so we cannot have a one-size-fits-all approach. We need to adapt, we need to contextualize, and we need to think about differentiation, both in terms of the definition of what our goals should be, but also in terms of the interventions that we roll out.
Dr. Raihanah, that's powerful. Adaptability, flexibility, and contextualization as required. So my next question would be to Dr. Yakubu from NHIA, and it's really to ask, one of the participants had asked a question that there is Ministry of Humanitarian Affairs that disbursed some money to the vulnerable group. How is NHIA thinking about partnering with them and leverage some of those funds for vulnerable groups to actually procure health insurance for them, so that their health will not be a problem when they need to access some care for their family? Over to you in 30 seconds to 1 minute, and the passing word for us. Over.
Dr. Afeez, On a lighter side, I want to ask why you are always timing me to. Is it that I speak too much or something? You're always telling me
So,
to. Okay, so I think it's wonderful. This coming from Ministry of Humanitarian Affairs. I will advise that they reach out to us directly and immediately so we can get this funded. We have offices in the 36 states of the Federation. We are able to quickly mobilize and get these people on health insurance. And this is no challenge at all. We have various programs, the Basic Healthcare Provision Fund, but we can easily customize a program under what we call the gift ship, which is the program that we run for the informal sector, the group, individual, and family social health insurance program. We can easily enroll there. Where we need to partner with the state social health insurance agency to provide those health insurance, we are also able to quickly react to that. And for my parting word, I want to urge everybody who is on this webinar this evening to please tell someone about health insurance today, before you sleep. Call somebody and tell them they need that. Health insurance is actually operational in Nigeria. It is working, and we are ready to receive you. If you give us a call, we are able to direct you to where you can easily get a health insurance. And also to say that HIV is covered. What we don't cover is the drugs, the ARTs, and that's what we are making. So HIV screening, treatment of opportunistic infections, we already cover, but we don't cover the ART, and which is a very big part of the management of HIV. This is similar. This is the same with tuberculosis. So we do a lot of those work around the complications, but because of donor funding that has existed in the past, that's why we get the perception that NHIA does not cover TB and HIV. Thank you very much,
yeah,
Afeez.
thank you so much, Dr. Yakubu. And yeah, thanks for helping put some clarity into that. Yeah, it's part of our mandate to ensure that we communicate all of these reality. So we'll make it part of our assignment to also ensure that we increase the awareness around all of the brilliant work the NHI is doing, as well as every other agency. They are looking to increase the cost of living for every Nigerian and improve overall life expectancy that we look to see. So thank you very much. Everyone on this call has been urged to be the change agent that we want. And my last question will be to the secretariat who house all of our healthcare system at this point, which is the sector-wide approach unit of the Federal Ministry of Health and Social Welfare. My question to you, and yes, in the spirit of equity, if you can in 20 seconds, is Dr. Alezira, kindly help answer that, yeah, the NHIA, the FM, whichever one is doing a lot of initiative. Well, most of the policy that you will formulate, we still need the NHIA to help translate that into ensuring equitable access to every Nigerian. So just in a few seconds, can you tell us what the relationship is between the swap office and NHIA? Are you ensuring there is synergy between the two bodies? And as you answer that, give us the parting word that you want us all to go home with. Over to you. Hey, Dr. Alezira, are you on the call? Okay, so while we are waiting for her to be back on the call, I would like to thank all our panelists for all of the brilliant work that you've done, and I will transfer this back to Dr. Abutalib to help us run this up while appreciating everyone that has been on today's call. Over to you, Dr. Abutalib Abdusalam.
Thank you so much, Afeez. It's been very great listening to you all. And I think you made my job significantly easier in summarizing the key insights and takeaway. So I think the part of my job that is left is just to thank you all. So I want to thank the keynote speaker, Dr. Gafar Alawode, the panelists, Drs. Raihanah, Ibrahim, Yakubu, Agada, and Helzira Gamvo, for a very lengthy but very insightful discussion on the way forward for us as a country. Also to run through a number of next steps, right? We'll be sharing webinar materials, including recording of this webinar and key resources such as the Q&A, as you had promised, via our live streaming platforms, LinkedIn, YouTube, and also our social media channels. We'll also share a short poll via email for your feedback and your insights that will help us to improve future sessions. And finally, on a parting note, this conversation doesn't end here. In fact, it's the beginning. We want you to keep on engaging, collaborating, and driving action towards sustaining health financing solutions in Nigeria. It's a huge thank you to the audience and everyone once again. And thank you for being a big part of this conversation. Have an excellent day.
Thank you and bye.
Yeah,
Bye. Thank you so much. Thank you, everyone.
All right, bye.
Bye.